Hello friends. The lower urinary tract symptoms in a male patient who is more than 50 or 55 years of age is a fairly common clinical problem. Through this presentation, I want to talk to you about some important points which you should keep in your mind when you see these patients for making a diagnosis and also doing initial treatment. As I said, that low urinary tract symptoms are very common in elderly males. So the male patients first report to their treating physicians. And this is the practice all across the globe. But physicians have to treat many more diseases like diabetes, hypertension, heart disease, thyroid, and so many others. Consequently, there are situations of misdiagnosis and there are situations of inappropriate treatment. And this is largely because the clinical training to manage low urinary tract symptoms and the knowledge and experience which is required to manage low urinary tract symptoms in elderly males is not uniform across the world. And I have also experienced that the very perception that what is a high risk group in this symptom complex, the identification of that high risk group is often missing. So with these intentions, I am talking to you in this presentation and I will put forth before you a very simple rule of 4 in every aspect of management of this clinical syndrome. Before I begin, then let me make it very clear that what I am talking to you is not a complete repository of the guidelines that come to us as a urologist from various associations, but this is a summary and this is my own personal impression. And whatever I am sharing with you in this presentation is basically intended to minimize the misdiagnosis and inappropriate treatment at your end. And secondly, improve outcomes of patient's treatment under your care. So these two are the purpose of this talk. Now, when you manage a low urinary tract symptom patient, and I am talking all along of the elderly male, you are supposed to do 4 things to this patient. You want to take a clinical history, you move on to do clinical examination, you advise some simple investigations, and then you do treatment, right? So these are 4 areas wherein you progressively move. In every area, you can use the rule of crucial 4. When I say crucial 4, these are 4 points which I consider most important in every area. So that's what I'm trying to highlight. Let us first stay for a while in area of clinical history taking. What are these 4 points in history taking? First of all, you should be able to identify that in that particular patient is the disease in early stage or the disease in an advanced stage, right? Because advanced disease requires a different kind of approach. So what are the indicators of advanced disease and can you find that in history taking? Yes, you can find out if you remember these 4 indicators. If the urinary frequency of the patient is markedly increased, he is going to toilet day in day out, in day as well as in the night, and it is close to more than 50-20 times per day. This happens because patient is not able to empty his urinary bladder properly. He is passing urine little bit. The second symptom is, which you should take seriously, if patient complains of overflow urinary incontinence, means he's wetting his undergarments in the daytime. Third, if patient complains that even after passing urine, he continues to feel fullness in the lower abdomen and the feeling of incomplete emptying persists even after voiding. This is a symptom of advanced disease. And finally, if any patient of low urinary tract symptom tells you that I am wetting my bed in night, this indicates the patient is sleeping with a full urinary bladder, and in the night as consciousness goes away, sphincteric control goes away, the bladder starts leaking urine. This is a serious symptom, right? So friends, all these four symptoms indicate advanced disease. Then in your history taking, look for, is there a possibility that the patient is having a complicated disease? What are the common complications and how you can find them out? Remember again, four common areas. First, if any patient, elderly patient, male, complains of pain during passing urine, and we call this as dysuria, this is indicative of infection in the lower urinary tract. I have sometimes also seen it in cancer prostate, but for your purpose, urinary infection. Second, any patient who complains of gross hematuria, please pay proper attention to this symptom. This may mean occurrence of cancer in urinary tract, occurrence of stone in urinary tract, so many other things. And again, because of BPH. If any patient complains of fever with increased urinary burning sensation and frequency, again, this is indicative of infection in the lower urinary tract. And finally, the fourth point, any patient of persistent low urinary tract symptom, when he says that I have noted increasing edema on my feet, pedal edema, this indicates onset of renal failure in these patients. So remember these four indicators of complications in that patient. Then, since you are a physician, it is your duty to find out why this particular patient is developing low urinary tract symptoms. I'm not saying try and find out etiology here, but I'm trying to say most patients have some or other predisposing factor in them because of which they develop low urinary tract symptom. And those patients who have LUTS because of predisposing factors, they behave in a different manner. So what are those predisposing factors? And I call them as background predisposition. Again, four. First of all, any male who has a positive family history, you must record that in your document. Ask about the dietary pattern. Those males who have predominantly non-vegetarian diet, more prone to have low urinary tract symptom, and they often do not respond to a treatment. Anybody who is having coexistent metabolic syndrome, and you know this fairly well. Anybody who has sedentary life, again, it is related to metabolic syndrome. So these 4 points should be carefully asked for in history taking and be noted in patient records. Then there are some diseases which initially look like as if it is BPH. When you see a patient or low urinary tract symptom, the first impression that comes to mind is, oh, his prostate may be enlarged and these are symptoms due to prostate. But that's not true. There are some other things which are there in the man which can just give you same set of symptoms. So I call it masqueraders. And what are those 4 areas I want you to find out in history taking? Check with the patient that can he retract his foreskin completely or not. Because many elderly men do not attend to their personal hygiene. The prepuce is non-retracted, they develop phimosis, and because of phimosis they have obstructed urinary stream and you are giving treatment for prostate, right? So if you have short time and you cannot examine the patient's tip of penis, you can surely ask the patient about whether he can retract his skin or not. Is there a history of prior urethral instrumentation, like a catheter placement? And this is very common in elderly males during angioplasty, during any operations, right? Very common is these days joint replacement surgeries. So they are catheterized. And because of catheter related complications, they develop low urinary tract symptoms. Check with the patient whether his urinary stream is thin or the speed of flow has decreased. The both things are different. In this picture, I tried to show you what is the meaning of thin stream. Thin stream refers to caliber, not the force. Check with the patient, is your stream as thin as a pencil tip, right? Thin stream means patient may be having narrow meatus or stricture in his urethra, which is giving rise to these symptoms, not prostate. So if you ask these small points, ask about recent onset backache. Many men can have backache because of lumbar spondylitis, but then it is mild, present for a very long time. Any male who is having low urinary tract symptom starts developing a recent onset, persistent, significant backache. Please remember, it may be due to metastasis from cancer prostate. So if you remember these only 4 things in your history taking and you ask the patient in a record, you will avoid missing a very common diagnosis and you will avoid making an inappropriate treatment. So I hope I have made clear to you, you should take whatever history you want to take, right? But please do record these 4 points in 4 areas. So that is about clinical history. Let us move to the clinical examination. Again, what are those crucial 4? These crucial 4 are: number 1, if anyone who has a palpable or percussible urinary bladder. This means urinary bladder is full and the patient is in a state of chronic urinary retention. Patient may not be aware about this, but it is your sacrosanct duty to palpate lower abdomen to discover this, right? Don't rely on ultrasound alone. Clinical examination is also very important. Do not forget to check the sensations in the perineal area. And I've shown you here what is the perineal area, because if sensations are lost, it may be an indication of a neurological disease in spine. So this may be a case of a neurogenic bladder, not a case of BPH. So just simple check of perineal sensation, you will discover the disease immediately. Thirdly, please expose the patient's garments, examine the tip of the penis for any phimosis or for any meatal stenosis. These 2 things are very, very common in rural males in our country. And then, if you have time and you have experience, you should do a digital rectal examination wherein you should check the tone of the anus, anal muscular tone, and also check all the details about prostate. Now, I must confess that the physician colleagues are often not trained to do this test and they do not do it for the want of time and for the want of lack of training. In that case, you mention in the patient record that digital rectal examination has not been done and to be done by a urologist. Please tell the patient the importance of this test. And next time when this patient will come to me, he will himself tell me, "Sir, please do my examination." So that is the role you can play in these patients. So that was about clinical examination. And then moving to the what are those crucial 4 points in investigations that you will advise to this patient, right? So first of all, advice for a urine analysis. The intention is to see for pus cells and also red blood cells. And I've already told you, urinary tract infection and hematuria are regarded as complications. Plus, pus cells and RBC can also indicate other diseases in urinary tract. So do not ignore the importance of simple urine analysis. Recommend serum PSA. Now here I want to tell you, if you are treating a male for the first time who is more than 80 years of age, there you may not do serum PSA. But in rest all, you should do a serum PSA, total serum PSA, as an essential investigation. You must check serum creatinine if you do not know this report beforehand. Some patient says, I had this check done already, my serum creatinine is normal, then you need not repeat it, right? But if this test has never been done before, please do this. And do not forget to advise an ultrasound of kidney and urinary bladder and prostate. And in the ultrasound, please write, kindly also check post-void residual urinary volume. So I often write ultrasound KUB plus PVRU. This second part is very vital for knowing the extent of the disease and knowing response to the treatment. So that was about 4 crucial points in investigations. Moving to the diagnosis area, when you're about to write down on your notes what are the final diagnosis, remember diagnosis here is split into 2 parts. One is a urological diagnosis which pertains to prostate and urinary bladder and urethra, and other is the overall diagnosis of the patient which has relevance while you are managing this patient. So what I mean by diagnosis, a differential diagnosis that you must keep in your mind when you are treating these patients. Now what is the urological diagnosis part, which may be there in addition to prostate, in addition to BPH, right? And maybe compounding the all clinical picture, or that may be the sole reason for his problems and you are treating prostate wrongly. Therefore, the basic knowledge for you is very necessary. And here in this picture, you will see again 4 areas. And I want you to remember in each area 4 diagnoses. Okay. So in bladder, keep in mind that patient may be having neurogenic bladder or a large diverticulum in urinary bladder, or sometimes cancer of the urinary bladder, which is sitting at the bladder outlet and causing obstruction in the flow, or a simple stone in the urinary bladder which will mimic symptoms of prostatic enlargement. So just keep those 4 diagnoses in your mind and look for them in ultrasound or in your examination. Then is prostate. Now in prostate, of course, you think it is BPH. But please remember other diseases within the prostate, like cancer prostate, like prostatitis, or development of abscess in the prostate gland, which is very common in patients who have uncontrolled diabetes and chronic constipation. The third site is urethra. And in urethra, one can have stricture, the narrowing in the lumen, stone stuck in the urethra somewhere, infection in the urethra like urethritis, or some trauma, right? External trauma. And all these things can give rise to same set of low urinary tract symptoms as would be caused by BPH. And finally, diseases that occur in the penis, like phimosis, I have also mentioned about this already, paraphimosis, elephantiasis because of filariasis, and 4th diseases lichen sclerosis, also called as balanitis gerotica obliterans. In this area, the patients develop whitish patch, thick whitish patch on the tip of the penis and skin. It can become thick and indurated, causes itching, and it causes narrowing of the external urinary meatus. So friends, just simple way, 4 sites, and at each side common 4 diseases. Keep in your mind all the time. Then what is the extra urological diagnosis? When I say extra urologic, I mean not within the urinary tract, but outside the urinary tract. Patient may be having a comorbidity which is compounding the symptoms of low urinary tract. See, you should know that the low urinary tract is a part of the human body. So you can make a diagnosis of disorder in low urinary tract, but remember it is happening in the patient, full patient, and each patient is different in terms of comorbidity, and therefore the degree of symptoms will be different and the response to treatment will also be different. What should you keep in the mind in cardiac status? And I need not be telling you because you're all masters in this area. Any episode of coronary artery disease, congestive heart failure, hypertension, because the therapy that you give for treatment of these patients, like diuretics, like beta blockers, they can influence the behavior of low urinary tract and therefore the symptoms of low urinary tract. Then in neuropsychiatric makeup, patients can have some illnesses like history of cerebrovascular accident, Parkinson's disease, so common, dementia. Now all these three common neurological disorders, a history of head injury, a history of brain tumor. So any central neurological disease will compound the low urinary tract symptom. They themselves can generate low urinary tract symptom and look like BPH. Anybody who has endocrinal alterations like diabetes, both controlled and uncontrolled, obesity, hypothyroidism, and finally musculoskeletal system. The osteoarthritis of knees is very common. Patients find it difficult to walk. So anybody who has painful knees will find it very difficult to go to toilet again and again. So for the frequency and urgency, he'll be extremely uncomfortable. Disc disease is also very common. Sometimes disc prolapses and compresses the cauda equina nerve roots and increase the low urinary tract symptoms. So friends, when you are making a final diagnosis, at that point, please consider these differential diagnoses as well. Now let's quickly move on to the crucial 4 in the treatment. When you have to treat the patient, again, what are those 4 areas? And I want to touch upon general guidelines, simple rules. I want to touch upon specific guidelines related to the low urinary tract. I want to tell you when the patient requires operation. And finally, when patient does not require operation, even in that case, patient may be having some complication and you need to refer the patient to a urologist. So I'll touch these 4 areas in treatment. I'm sure you know that these patients of low urinary tract symptoms today are treated by a variety of drugs like alpha blockers, 5-alpha reductase inhibitors, anticholinergics, right? And many drugs like tadalafil. So you have plenty of drugs at your hand, and you being physician, you can easily play with these drugs and give them for a good response in the patient. But then while you are treating the patient, just before you are starting the medical therapy, you must remember these four important points. Now, what are 4 crucial general guidelines? Please remember these 4 points as a general rule before you treat any male with low urinary tract symptom. Number 1, never begin pharmacotherapy, which includes both alpha blockers and 5-alpha reductase inhibitors, till you have addressed the lifestyle factors, which means many patients take increased liquid, increased tea in our country. The increased liquid intake, many people take milk before they sleep in the night. These things are very common in our society and they compound low urinary tract symptoms. So please check this. No point in giving therapy unless you have addressed this small thing. Number 2, never start pharmacotherapy without considering patients' comorbidities and co-prescriptions. These co-prescriptions and comorbidities will enhance side effects of the therapy that you're going to give, and they may also mar the effect of the medical therapy. Never start antibiotic without the documentation of urinary tract infection. elderly males are very sensitive to side effects, particularly fluoroquinolones. Their joints start aching, the tendon starts aching, the sleep goes away. So many things happen. So don't be casual in giving them antibiotics till you have a documented infection. And finally, never miss to treat constipation if it is present. Presence of constipation worsens low urinary tract symptoms. The moment you give them good laxative, the bowel habits become normal. 20-30% of low urinary tract symptoms will go away. So remember these general simple rules. Then what are specific guidelines related to the disease of prostatic obstruction? And here, never choose alpha blocker at random. Somebody has told you or you have fancy for the particular drug, you start writing same drug to everybody. We have plenty of alpha blockers these days. Alfidocin, tamsulosin, silodosin. These are common alpha blockers. You have to choose this. If I were to give you one single way to choose, I would say go by the age of the patient. Anybody who is sexually active, less than 50 years of age, give him alfidocin. If somebody is of the age around 60 years, not sexually active very much, you can give him tamsulosin. And if somebody who is beyond 70 years or so, here you have enhanced risk of cardiac problems, co-associated cardiac comorbidities. So give them silodosin. Silodosin is a very cardiac safe drug. So this is a simple way to remember where to use alfidocin, where to use tamsulosin, where to use silodosin. There are many other small points that we do as specialists, but at your end, just simply follow the rule, the guidelines by age. Never combine two alpha blockers. This I have seen very often. In your effort to increase the response, you give them two alpha blockers. There is no benefit by combining two alpha blockers. On the contrary, the side effects will increase. Number third, never start antimuscarinics, or also known as anticholinergic medications, without checking post-void residual urinary volume in the bladder. Why? Because antimuscarinic therapy will reduce bladder contractile power. Suppose somebody has 100 cc post-void residual urinary volume, or let's say 200 cc post-void residual urinary volume, and you start him on anticholinergic because he was complaining of increased frequency. The moment you give him anticholinergic, his bladder will relax and the poor patient will develop urinary retention. So this is a serious side effect. And the fourth point is never start alpha reductase inhibitors, which means finasteride and dutasteride, without checking the PSA of the patient. Because dutasteride, finasteride, when taken for long duration, will suppress the PSA values. And after that, the follow-up of the patient, whether he is developing cancer prostate or not developing cancer prostate, becomes very difficult. So before you start any of these drugs, please check serum PSA of the patient. So these are 4 points related to low urinary tract symptom. Now, what are the 4 crucial indications of surgery? Patient is under your treatment. He is in your follow-up. What is that which, if he develops, you have to give advice for surgery? Number 1, anybody who develops repeated urinary retention. If somebody develops one episode of urinary retention, put a catheter removed after 3-4 days, patient voiding all right, this is okay. But if somebody develops repeated urinary retention, acute retention, or somebody develops chronic urinary retention, he should be advised surgery. Number 2, anybody who has developed bilateral hydroureteronephrosis because of back pressure in urinary tract and is developing or not developing renal failure. So bilateral hydroureteronephrosis with or without renal failure is an indication for surgery. Anybody whose low urinary tract symptoms are not responding to your treatment and his prostate is significantly enlarged, he needs surgery. And finally, if a patient is not willing to continue a long-term medical therapy because of the cost factor, because of lack of availability and so many other reasons, he should be advised to undergo a definitive treatment, one-time fixed final treatment, that is surgery for prostate. So these are 4 indications for surgery that you should keep in your mind. What are the 4 crucial indications for referral? The patient is under your treatment, he is showing improvement, but then something goes wrong somewhere, you think this patient should be sent to a specialist, and these indications are non-responsive urinary tract infection. This is first situation. I have seen very often physician friends treating urinary infection in presence of prostatic obstruction, particularly in diabetics. Here, the UTI takes very long time to go away. So it is not 5-day therapy or 10-day therapy. It requires a long-term therapy. It requires more consideration of investigations. So please refer the patient for at least one-time evaluation by urologist. Anybody who has gross hematuria, his urinary tract should be thoroughly screened by CT scan or cystoscopy and whatever things. Anybody who is having refractory urinary retention, which means the patient is having post-void residual urinary volume more than 150 cc, 200 cc, you are giving therapy and this is not improving. Patient can be having various other reasons for this and should be sent for a specialist evaluation. And finally, if you discover increased serum PSA at any point of time, please send the patient to a specialist. So I hope I have made my points clear to you, and I hope you remember this rule of crucial 4 points in every area of your interaction with the patient. Thank you very much. I'll be happy to take your questions, if any.